Sorry, where am I?
Yeah, there we
Yeah.
are. We are all here, and that is recording. So, thank you, everyone. We've got quite a few people who have joined in this evening. It's lovely to see so many. Just a little bit of housekeeping. This session is being recorded. So, if you need to dash off early, you should get an email tomorrow where you can access the recording both through my IVF answers, but also through YouTube. And please use the Q&A for your questions. We do already have quite a big question in there that we will get to very shortly. But first and foremost, we will start with introductions. So my name is Sandy Christiansen. I'm a clinical embryologist. That's my background. I have been working in the fertility industry for the past 16 years now. I started working as an embryologist in Sweden. I have an ESHRE certification as a clinical embryologist, and I'm HCPC registered in the UK, where I am currently based. But for the past 5 years, I've actually shifted from clinical work and work more with patient support, navigating fertility issues and fertility treatment as a patient advocate and fertility educator. So we are starting this new series with my IVF answers on Ask my Embryologist, and tonight we are talking about embryo quality and is the best looking embryo always the best choice for transfer? With me this evening, I've got Dr. Daniel Hlinka, who's the laboratory
Hello.
director and owner of the Clayo Clinic, and Dr. Vladimiro Silva, who is the scientific director at Ferticentro and Procriar in Portugal. So I will let you both introduce yourselves. Dr. Daniel, tell us a little bit about yourself.
Hmm. I'm embryologist for a very long time, so it means that there is not enough time to speak about beef in the short, because I'm in the field for more than 35 years. But I am still active embryologist doing basic embryological work as ICSI, biopsies, etc., etc. What is I'm aiming now it is a connection between gynecology and embryology, because we will speak about it that the story of embryo starts from the oocytes, and oocytes is developing in your ovaries, and your ovaries are in your body, and your body is living for some time. So it means it is a very age dependent quality oocytes which starts in you, and we have to create healthy embryo after very long time being in your ovaries. So it means all these aspects of creation of embryology, viable embryos must be considered before we start the treatment. And therefore, to be very short, what is my function? For not only to teach my new embryologists in my labs, because I'm bridge between the old time embryology and new, very very cut piece of embryology, which is shortened just to 5 days of blastocyst culture, supported by some PGT genetic test, and that's all. Yes. And so I have to introduce all the parts of embryology which were used in the past, but it is very useful to use them even now in some specific cases of women. So therefore, I devote a lot of time, because I'm the owner and CEO at our clinic. So I devote a lot of time to speak with patients before they start the treatment, to have their realistic expectation from the treatment. This is in
Excellent.
short about me.
Thank you, Dr. Daniel. And I think very apt that bridging that gap between the gynecologists and embryology, specifically for focusing on egg quality and embryo development, and part of our topic tonight. And Dr. Vladimiro, please tell us a little bit about yourself.
Well, first of all, thanks for having me. Nice to meet you, Sandy and Daniel. I work in the fertility industry since 2003, so it's been 22 years now, so quite a long time. I used to be the lab director at the Portuguese clinic called Ferticentro. Then I was one of the founders, together with Dr. Joana Mesquita Guimarães, of Procriar in 2019, a clinic in Porto. Then we created a group called Assisted Reproduction Alliance, and we joined a clinic in Lisbon, and now we have other 4 clinics in our group in Denmark, the MyGuard group, and in Greece, the New Life group. So I've moved. I'm telling this just to tell you, because I've moved from a position where I was actually, I started by doing a little bit what you're doing right now, especially both of you actually. So I was talking to patients a lot. Then I moved into being more of a rat, a lab rat, and then I came back outside of the lab, and I spent a lot of time. I used to spend a lot of time talking to patients. I still do a lot of conferences and interventions with patients. I obviously also speak directly to patients on a daily basis, but nowadays my position is a little bit distanced from real practice in the lab, but obviously I still talk with the lab directors of our group and all the embryologists actually on a daily basis, and we are always reviewing the scientific information and everything else. So it's a pleasure to be here. Obviously, I will try to do my best to answer the questions. This is one of the areas. Just a little comment on the title of this webinar. Well, the title itself is a way for us to, is the best looking embryo always the best choice? Okay, this is kind of a reminder that we actually don't know exactly what we're doing, because we don't know the answer to that question. But I'll let you organize the debate, Sandy.
That's lovely. Thank you. I think, no, that's a very good point, and I'm sure we will have time to get to that too, and all of our thoughts around why that might be a case. I just want to go ahead and start addressing a very long question that we've got in the Q&A. So I'll break this up into little bits, and please, everyone else who is here tonight, feel free to drop your questions into the Q&A, please, if at all possible. And yeah, so first and foremost, I'll direct this to you, Dr. Daniel. How big a difference does a day 5 embryo versus a day 6 embryo make when attempting frozen embryo transfer? So do you think there's a difference between a day 5 and a day 6 blastocyst for frozen embryo transfer?
Basically, you have to understand the process of embryo preselection. First of all, before we start to answer this question, I would start with this previous topic. So it means if the best looking embryo is the best choice, because we have to clarify that we are in embryology, we are facing million years of evolution, and our goal to evaluate the embryo is not voting of Miss Universe. So it means it is not selection of the beauties and the best looking embryos, because during my very long career, I've seen a lot of very nice, cute babies born from totally ugly embryos. And vice versa, yes, because I can show you a lot of examples. For example, tripolar cleavages, when the embryo cleaves from 1 to 3 cells immediately, so-called direct cleavage, which make seemingly very nice embryos, because they are advanced, and embryologists which are not skilled would consider them, because they are nicely looking. They would select them for embryo transfer, but those embryos are totally abnormal.
Correct.
And now we are going to the further step by step. I will go to this differences between day 5 or day 6 embryos, but we have to understand what we are evaluating in embryos. There are two basic properties of embryos. The first one is viability. Viability means that what is the chance to develop the blastocyst stage after 5-6 days of embryo culture from fertilization. This is one thing. And the second one is genetic constitution. These two properties of early embryos are not correlating. We know that there is a lot of embryos which are totally genetically abnormal and can be seen as a viable embryos. Everybody of you knows a lot of embryos which are abnormal from meiotic abnormalities as Down syndrome, Klinefelter, Turner, Patau, Edwards syndrome. All these embryos produce are viable, very nice. So they can implant, they develop to term, but they are totally abnormal. So it means if we are looking for the embryo, we are looking for the embryo which can produce healthy child. Not all, to establish just a pregnancy, because pregnancy can be compromised by early miscarriages and fetus abnormalities. And if we are going to evaluate these two properties, we can consider that there are three main sources of genetic abnormalities. They are inherited, they are meiotic, so it means arising from oocytes or spermatozoa, but they are very frequent in women in advanced reproductive age. And then there are mitotic, so-called embryonic abnormalities arising as a result of abnormal cleavages. And these first two, so it means inherited and meiotic, can be recognized properly by microscopic observation or even using time-lapse system. Only those which are developing as abnormal embryo cleavages, they can be recognized, and then they can be used as an evaluation test. All the previous ones, so it means inherited and meiotic errors, can be recognized only after PGTA system or using PGTA, carrier mapping, etc., etc. So if we want to evaluate everything, we have to use combination of time-lapse system, of our grading system. For example, we use also our developed AI system, and we have to combine it with PGT testing. But now we are frequently going to very, very complicated situation, because a lot of older women having very high chances for meiotic abnormalities. So it means chances to have Down syndrome, etc. Those embryos are not viable, or they are not able to develop to blastocyst stage. So it means sometimes it is very balancing on the edge what to do, whether to have blastocyst or these embryos want to develop to blastocyst stage, or to transfer these embryos earlier after the 3 days. And then these women are, if they are pregnant, they have to undergo prenatal diagnosis. So let's go to the question you put. What is the difference between day 5?
It's complex. It's not a simple question. It is quite complex.
It's not really. You can never put a simple question what I can answer in the two sentences. Definitely, the difference, if the embryo is able to develop to blastocyst stage on the day 5, and let's don't speak now about genetic constitution, etc. It is a reflection of oocyte competencies. So it means oocyte competencies, viable, competent oocytes can produce the embryos which cleave in time. So every mitotic cycle is in time. So it means after 6 mitotic cycles, the embryo has more than 200 cells, and these embryos can produce viable blastocysts on the day 5. And then we have another group. So it means the embryos from pure responders or older women, they lack of mitochondria. So it means that this is energy substrate of this oocyte, and these mitochondria are lacking in embryo development. So it means all mitotic cycles are postponed. In such cases, we can find viable blastocysts on the day 6. And if we compare these two groups, definitely the first one is better. But even though these day 6 blastocysts, if they are just delayed, it should still produce viable pregnancies. But there is another group of blastocysts on the day 6, which are compromised by abnormal cleavage. So it means they are losing the cells. So they have no big number of cells to produce. So definitely, if you want to prefer day 5.
Thank you, Dr. Denny. We've got quite a few questions now, so we will have to zip through some of these now. I think one of the main things here is, is there a statistical significant difference in a same quality embryo on day 5 and day 6 if the right uterine environment is prepped? What are your thoughts on that, Vladimiro?
First of all, I think Danielle really pretty much covered all of our interrogations
all of the intricacies.
And so on.
Yeah, of course.
Yeah. So I think because we are talking to patients, I believe most of the audience is patients, so I will try to keep it maybe less technical in my answers. One thing that we all need to bear in mind, and again, talking to patients, is that humans generate abnormal embryos all the time. So we know that we are on the top. When we are on the top of our fertility, we get, a 25-year-old lady with a 25-year-old man doing things naturally on the right day without any fertility problems from each side. They only have 25 to 30% of success. Why is that? Yeah. Because of random variability around human cells, human sperm, human eggs. And so there is obviously the older, especially, and this is very related to women, the older a woman gets, the less likely the embryo is to be normal. And then we, in the fertility labs, in the fertility clinics, in IVF labs, we've been trying to assess the quality of the embryos for quite a long time. Okay, when I started 22 years ago, we were looking at embryos morphology, and what are we doing now? We are looking at embryos morphology. Okay, so obviously we are looking at it in a very different way. Nowadays, the norm is blastocyst culture. When I started, it was day 2, day 3. Very rarely we used to go to day 5 or day 6. You would never consider it, but obviously it became more and more common, and in the United States they often go to day 7. It's a cultural thing. So it's but the reality is that we are looking at the embryo's morphology. We are basing our opinion on classification systems. For example, where I'm from in Portugal, and also in Spain, we prefer to work with the ASABIR classification, which is ASABIR is the Spanish Association of Embryologists. In Portugal, we also follow those indications very closely. In other parts, it's the Gardner classification. There are many systems worldwide, and they are all good. Some of them are more informative than others, and obviously nowadays we are on the era of artificial intelligence. We have different systems. We have systems that use algorithms that value parameters that are not even understandable for the human eye. So it's very difficult. So going into putting it all together, what I would say is this: I'm just a kind of a disclosure of interest. I'm very much in favor of pre-implantation genetic testing, and when someone is in favor of something, they tend to see only the positive points of some theory or technology or whatever. It's, I believe, normal human behavior. So having said this, I will now justify why I'm so much in favor, because it will all goes down to the genetic quality of the embryo. That's the most important, because we look at morphology, and I'm sure you will tell that you have the same experience. If you look into a very good embryo coming from a 44-year-old lady and a not so good looking embryo coming from a 29-year-old lady, the chances of implantation are always higher with the embryo coming from the youngest patient. It's statistics. It is what it is. We know, like Daniel was explaining, that embryo development depends on so many factors. Some of them are caused by us in the lab with our manipulation. The pressure of CO2, the pH level, the temperature control, the quality of our incubators, the quality of our culture media. So some of these differences are actually caused by us in the labs, but we know. But what counts, obviously, is the quality of the embryos. The scenario that you were asking about, Sandy, is like if we put everything constant and just taking it out. Even in those circumstances, it's different. The way the ICSI is done, or if it's classic IVF, though the type of manipulation, timing between the stripping and putting the embryo into culture. I mean, there are so many things that might affect even the culture media. We all know that in some culture media, embryos go faster than in others. And for example, what's the day 5 and the day 6? Sometimes it depends on what time does your embryology lab closes. Because if the blastocyst is still starting to expand, you'll probably say, well, let's leave this one for tomorrow. Or if you work another 2 hours, then he's completely expanded and you will freeze it on day 5 rather than on day 6. So there are many different aspects here. I would say, and probably I will repeat this the whole webinar, it all goes down to the genetic quality of the embryo. And that depends on, obviously, a number of facts. The most important one is the embryo having a normal chromosomal constitution that is very dependent on the age of the female patient. Once I heard someone, a geneticist, talking at Escher, saying that should account for 70% of the likelihood of an embryo being genetically normal, and the other 30% rely on the quality of the sperm, because we all know the egg has some capacity to repair some DNA damage in spermatozoa. But so I think that's
This is excellent, because I think what you've both done in the past couple of minutes is highlight just so many variables that go into embryo selection, that go into the decisions that we make in the laboratory for embryos to transfer, the timing of the insemination, the timing of your laboratory, like when we're looking at the embryos, the timing of the embryo transfer itself, the development, if you're using time lapse or not, we'll be looking at the timings of the cleavages versus, once a day, or if we're doing PGTA testing, like all of these factors will contribute to what embryo gets transferred. And that's why there's not really a blanket answer for which, what is best, or, if there's a difference between the transfer of those two embryos. So thank you so much. Very great answers to this. It's been a wonderful discussion. So I'm gonna just kind of jump to another one. Here we've got a few more questions that have come in. And Dr. Daniel, can I get your thoughts on this? If you have one embryo left, would you suggest transferring on day 3 or culturing until day 5 and risk that culture? What do you think if you only have one embryo? That's a tricky one.
Okay, short answer, yeah. Let's start from the one point. We have to understand that the embryo is influenced by three factors: oocyte, spermatozoon, and in vitro conditions. Everybody must consider that in vitro conditions are not the same as healthy in vivo conditions. So it means in your body. And the embryos from different people are differently resistant to in vitro conditions. And if we are going to state some strategy for embryo transfer and embryo evaluation, we are starting from evaluation the previous history of the patients. And if they are coming to us having 46 and 45 years and do not accepting of the donation, and they failed to produce embryos to blastocyst stage. And you know what is usual expression of it. This is a natural selection of embryos. Those embryos which are not able to develop to blastocyst stage after 5 days would die even in your
To transfer,
womb.
yeah.
But that is absolutely not true. You know, we have a lot of patients, and this is what I said, that I'm bridge between the old approach and nowadays approach day 5 transfer. If I see some sensitive cases, so it means from previous history or of diminished ovarian reserves, when we can expect of less resistant embryos, I always start from the date 3 embryo transfer. There is a lot of results we had because you have to understand the statistics which are offered. Usually the centers or somebody say that we have 55% pregnancy rate after the day 5 transfer. But they do not speak about cancellation or cycle rate. So it means from 100 patients, they had a transfer just in 70% of them, and 30% of them were without any transfer. They do not speak about cumulative pregnancy chances. So it means if you have just one embryo for transfer, and we calculate the success of treatment by cumulative chances. So it means what are your chances to be pregnant after transferring of all embryos from this stimulation? And the more embryos we have, the higher cumulative pregnancy chances are. So it means if we just rely on day 5, day 6 transfer, we will shorten the number of embryos, and we do not calculate the cycles which are cancelled because there was no embryo for transfer. So what if we are going to personalized medicine? We have to evaluate the case by case, from the history, from the age, and again, we have to see what is happening inside of us, because in our laboratory. So final decision I'm making when I see the embryos in my time lapse, evaluating by our own systems, our own selection systems. So it means our grading is totally different from gardeners, because we are not evaluating just one picture or some structures of blastocysts, because it would be too late to evaluate the embryos. So this is very short.
Thank you, Dr. Dan.
So
You highlighted something.
definitely to your question, we use also day 3, day 4, day 5 the embryo transfer based on the history, on the age, but based on the quality and number of oocytes and resulting embryos which we can have in our lab.
Yeah, I think you hit something really important there earlier as well, which was on personalization. There's not really a blanket answer, but it's, you know, reviewing your medical history, your age, understanding a little bit more about all of these important factors before making that decision. Right, Vladimiro, I've got a different question for you here. Somebody is asking about donor eggs. So when using donor eggs, Do you get better embryos with fresh or frozen? Now, this person says that they had 15 frozen donor eggs, but only had 1 day 5 blastocyst.
Okay.
What do you think
So,
about that?
I mean, it can happen, obviously. So, so starting with what is the difference between fresh and frozen eggs? That's an important one. When we use egg vitrification for a long time, so egg freezing for a long time was not done because it was difficult. The results were done okay, and so on. When we started using vitrification, and when I say we, I say the whole fertility industry, that's because the vitrification techniques started to be implemented and the results were very good. If we go now to the main suppliers of vitrification methods, they all claim, and they show, and they have proven records of results always above 90%. It's very consistent wherever the supplier is, so we can have a lot of good survival rates after vitrification. Obviously, one thing is when you look at 1,000 eggs or 10,000 or whatever, and another thing is when you look at your personal specific cases. If the vitrification process is well succeeded, then the results that we obtain with the eggs should be the same as we had before freezing the eggs. We all know that sometimes, and the reason why, for example, embryo survival after vitrification is 98, 99%, and egg survival is only 92, 90, a little bit around that, is because eggs are more delicate cells. They have more water inside. It's a more delicate process. So the lab needs to be really optimized. The person doing the vitrification should do it every day, multiple times a day for quite a long time, because there's a learning curve. And sometimes when you go on holidays and you come back from holidays, you need to practice a little bit just to recover your hands, so you can be sure that you will have good results while working with real cells. Okay, so it's a manual technique. There are some automated devices, but they are not as good as the manual techniques, and so it can happen. Okay, so in that case, we obviously don't know what happened. Maybe the donor eggs were not that good in the first place. Maybe there was a male factor involved. We don't know exactly what happened, but the reality here is 90% of the times the results should be the same. 10% of the times the results are worse. And I think that with this take-home message, we can cover all the situations that might happen.
Yeah, absolutely. Just a moment, Dr. Dan. I think one of the important things there is that, in our laboratories, we do have certain KPIs that we try to adhere to as well. And it depends a little bit. Were these frozen eggs from your own clinic? Were they transported? Are you using the same practices for the freezing and thawing? There are lots of factors that go into those frozen eggs as well. And then I would say, according to KPIs that I've worked at, 1 blastocyst from 15 eggs is not really hitting the mark. But we also don't necessarily know that fertilization rate or what the development was like from day 3 to day 5. So there are a lot of factors there that, as embryologists in the clinic, we would be able to pinpoint and say something might have gone a little bit askew here, and would try to correct or adjust in the next cycle. Go ahead, Dr. Daniel.
Just one comment to the first question, the difference between fresh and frozen embryo transfer. Because I am facing very frequently by this question from my clients or patients, and they demand frozen embryo transfer because all my women around me, they are pregnant from frozen embryo transfer. But this is just statistic. Yes, because those women which are pregnant from fresh embryo transfer are in minority, because all the repeated embryo transfer are performed from frozen embryos. So it means if you have 100 women, and after the first fresh embryo transfer, 20% of them are pregnant. 60% as a cumulative pregnancy rates are pregnant from frozen embryos. So it means this is of general opinion, public opinion, and even between IVF specialists that frozen embryos are better. But I think that the whole IVF is invasive. So it means we have to consider that I call it that 100 times nothing would kill the elephant. So it means if we don't need to do something, this is the case also biopsies. So let's don't do it. So if there is a chance to transfer fresh embryo, if there is no risk of hyperstimulation, if there is no high level of progesterone, which makes premature endometrium maturity, etc. So it means this is followed why we should not perform a fresh embryo transfer, but in other cases I would prefer a fresh embryo transfer. So definitely there is no any advance of frozen embryo transfer when compared to fresh embryo transfer. It is the other side of pregnancy, because to pregnancy we have to have viable embryo and receptive endometrium. This is question of body.
Excellent. Thank you so much. We've got a sensitive question here. Someone who says she's 46-year-old and had IVF with her own eggs. They had 4 eggs retrieved, 3 embryos fertilized, but they arrested on day 3. The husband has DNA fragmentation and Zymote was used. Asking if they should try again with own eggs or if it's best to consider donor eggs. I can thank you for sharing so much detail. I appreciate that. Is it's a difficult thing to consider and possibly not something that we might be able to answer for you. There are a lot of things that would go into consideration for that decision. Vladimiro, what thoughts do you have on this?
Just to confirm, this patient is 46. That's what you said.
46 years old, yes.
So I think here this is one of those cases where my answer will really depend on PGT, pre-implantation genetic testing, because so just explaining to the public what is PGT. We create the embryos. We take the embryos until day 5 or day 6, and then we do a hole in the embryo. We retrieve some cells, 5 to 10 cells. We send those cells to a genetics lab, and when we retrieve those cells, the embryo has more than 100 cells, and so these cells are taken from a part of the embryo that is called the trophoectoderm, that is considered to be representative of the total genetic constitution of the embryo. And so theoretically, the analysis of these 5 to 10 cells will tell us whether this embryo is viable or not. Okay, why am I advising this to this patient? This will not increase her chances of having a baby, okay? But it will change the type of information that she has. So nowadays, with the quality of our embryologists, the quality of our laser systems, it is the chances of the embryo being damaged by a biopsy and being frozen, vitrified, and then thawed for a subsequent frozen embryo transfer after the procedure. So the chances of the embryo being harmed by the procedure are very low, okay, if obviously in good quality clinics with good quality embryologists, and that will mean the world to this patient, because if we get to a moment where we just don't have blastocysts, which seems to be the case, or if we have blastocysts but they are not viable, and that happens 1, 2, 3, 4, 5 times, then it's a personal decision the moment where you decide to go to egg donation. We know the statistics. At the age of 46, we're looking to maybe less than 1% chance of having a viable embryo. Obviously, having said this, probably all of us have seen patients having babies at the older than 46, but those are the very rare cases. Okay, in 22 years of activity, I saw for a 51-year-old patient getting pregnant naturally. After getting pregnant with egg donation, then at 49, at 51, she got pregnant naturally. I've seen patients with IVF. The older that I've seen are exactly 46 with their own eggs after the age of 46. I never had a case, but obviously, if you go to the statistics, there are cases reported. It's a question of chance. These things are so rare that this is the reason why we don't see them all the time. So it's a very personal decision regarding. So if you feel like you want to have your baby, move on with your family as soon as possible, I will strongly advise you to go through egg donation. If you feel that you are still not ready to make that move, you are producing eggs, obviously 4 eggs. If you feel strong enough, also financially strong enough to try 2 or 3 more times, it's medically acceptable. We can try. I would definitely advise you to test your embryos to help you decide. Okay, testing the embryos will not improve their quality. If they're bad, they will remain bad. If they're good, they will remain good. But it will help you to make a decision. Okay, it's just about making a decision. If you're not changing your mind because of that decision, then you don't do PGTA. Okay, you can say, I want to transfer my embryos no matter what. Then it makes no sense to do the PGT. Okay, the PGT is for people who are hesitating between using their own eggs or moving with egg donation. Okay, so it is something that we really need to analyze, discuss with the patient, talk about money, talk about physical effort, talk about chances, and also what it means in terms of her family, the relationship with her partner, if she has a partner. So it's a very personal discussion that involves physical, technical, medical, psychological, economical aspects. So it's a complex decision. But in these patients, all patients above 37, I recommend PGTA. In a case such as this, I would for sure recommend it.
Yeah. Thank you so much for your caring answer. Dr. Daniel, I've got a separate question for you. And this is someone who had problems, I think, maybe a bit of side effects from the injections from her first IVF cycle, wants to try natural IVF, worried about the doctor only being able to collect 1 egg. She's 40 and has a good AMH with about 12 to 14 eggs per cycle. Do you think natural IVF would be a good choice?
Natural IVF?
Mm-hmm.
You know, this is the... Try to imagine. Let's start. What is the biggest advanced steps in IVF? It was hormonal stimulation, ICSI procedure, and vitrification. Without these 3 steps, IVF would never be in a situation like it is. And frequently, because it is very common in our conditions that some women are afraid of stimulation because of cancer. There is very big myth about the stimulation. My question is why onco patients are undergoing hormonal stimulation before therapy, if it would be the risk. I don't want to comment it anymore, but let's speak about chances in natural cycles, because after normal hormonal stimulation, we can collect, for example, 12 oocytes, 10 would be fertilized, and from these 10 fertilized, we can have five viable embryos. So it means in such a case, we can have cumulative chances. If the pregnancy chances after one embryo is around 30%, and we have 5 embryos or 6 embryos, the cumulative chances to be pregnant from this one cycle is around 95-98%. So it means in reality, usually these women are pregnant after 2 or 3 embryo transfers. So it means let's calculate 12 oocytes, and let's speak about it in natural cycles. Natural cycles is not 12 months, 12 mature oocytes, because 1 month will finish. There is no follicle, or it was ovulated, or the oocyte wasn't retrieved, or the oocyte wasn't mature. If this was matured, it wasn't fertilized. It was very fertilized. The embryo development is not correct. So it means it doesn't mean that 12 months is 12 oocytes. So it means if somebody wants to suffer every month from unsuccessful natural cycle, let's undergo it. But from my experience, after 3-4 months, everybody is totally spoiled from it. I don't mind a natural cycle if they are waiting for agreement from insurance companies. So it means until this formula and approval, they are waiting for this approval. In the meantime, they will come for natural cycle. If God wants, it can happen. But from my experience, the chances for pregnancy in natural cycles are around 1 to 2 maximally %. But you would be, as a couple, you would be totally destroyed. So I would never recommend anybody to undergo a natural cycle for IVF treatment. This is my opinion.
Well, thank you for your answer. I think that would be possibly a general consensus across the board. Vladimiro, I've got a question for you, and this is about a chromosomal translocation. So I think that's for you and your love of genetic testing. So this person says, our partner has chromosomal translocation. How can I support the egg so that it combines properly with his sperm and results in a healthy embryo?
Unfortunately, there's no way to do this. We are, just to explain to everyone what is that, what a chromosomal translocation happens when a part of a chromosome is placed in another chromosome and vice versa. A part of this other chromosome is placed on the initial chromosome. So the amount of DNA on that person is the correct amount of DNA. So they have all the genes they need to be normal functioning persons. However, when their gametes are formed, so in this case, when the sperm is formed, the spermatozoon is formed, the DNA is split in half. So an adult has 46 chromosomes, 23 pairs. And so when we produce our sperm and eggs, we only share 23 of our 46 chromosomes. However, if we share that chromosome that has an extra bit or a missing bit, we will be sharing the wrong number of the wrong amount of DNA to form the sperm or the egg. And in that situation, the embryo, in principle, I would say, almost certainly will not be viable. Medicine doesn't have an answer for this. There are no known methods for us to assure that a certain part of that the wrong chromosome is not shared, but just the right one. So these persons, for every affected pair, they have a 50% chance of sharing a good chromosome or a bad chromosome, which means that the chances of having a normal embryo are always lower. Obviously, we cannot say 50% lower, but because it's more complex than that, but yes, they are lower. What we can do is to create the embryos and then check them and see what happened. So there is a chance, I've seen cases like that, where all the embryos were affected. I've also seen cases where none of the embryos was affected. Okay, so it's really, and obviously different portions, 1 in 5, 2 in 5, whatever. So it's really a question of luck. Okay, and there's nothing that medicine can do to help you. Just we can only check the final result. If the embryo has a correct number of chromosomes, we can transfer it. If it has not the correct number of chromosomes, we should not transfer it, and the only solution is to try again or use donor cells.
Thank you so much. Right, I've got a few more questions. We'll try to get through them. We only have 9 minutes left. These are some excellent questions, and thank you all so much. No, that's fine. So we have a question here. So one embryo was quite fragmented and slow in development, but by day 5 it had improved, and it was a 4AA for transfer on day 5. What are your thoughts on this? Is that considered good? Good chances? Dr. Daniel? What are your thoughts?
If I caught it, so it means it was fragmented and then improved, and there was a blastocyst. So it means this is a situation of what I mentioned at the beginning, when the embryo can be compromised in development, and if there are some abnormal cleavages, the embryo have several rescue mechanisms. This is why I told you that we are facing million years of evolution of embryo. So it means the embryo can save some cells which are normal. And until blastulation, until blastocyst development, the embryo sequestrated these abnormal cells under zona pellucida, and these cells are considered as fragments. And at this time, to speak your language, these embryos are very ugly, because they are not resemble those which are we can see in books and in literature, etc. So it means 8 cell stages and Morla stages, etc. There is a lot of fragments, but under these fragments, then there can be the healthy nucleus. So it means several cells can be euploid, and from these 2 or 3 or 4 cells, they continue their development, even though they were compromised with the number of cells. So it means finally, under day 5, you can see the growth of these embryos, and their separated cells are squeezed under zona pellucida, and finally you can see a very expanded blastocyst. Usually those embryos are a little bit slower than those which are healthy, because they have less cells. So it means usually under day 5 they are as an early blastocyst, and if somebody wants to use them for biopsy, they wait until day 6 to have more cells to perform a healthy or safe biopsy. But definitely, this is the discrepancy between ugly embryos having a lot of fragments. On the day 5, there is the nice blastocyst. So it means finally you have to decide, because this is embryo scoring, and embryo scoring is always performed between the embryos of couple, not between the embryos between different couples. So it means if it is the embryo developing to blastocyst, it would be transferred, of course.
Perfect. Thank you. This one was for you, Vladimiro, about PGTA testing. So they're doing a donor egg IVF cycle. They don't want to waste time and risk a genetic issue. Do you think PGTA would be useful even if the egg donor is young?
So there are two sides of this question: the technical side and the legal side. So, if I was making the laws, I would say yes. That would be my choice. I would do PGTA always if I could. However, it is not legal, at least in Portugal. In some countries like Spain, you can do PGTA whenever you want. In some other countries, there are age cutoffs, female age cutoffs, regarding the time when you're allowed to do PGTA. Why are there those cutoffs? Because chances of having an abnormal embryo are very low with egg donors, supposedly the lowest possible, because so the patients that are listening to us understand, when we are looking at PGTA, we are looking at chromosomal abnormalities that are very likely to be originated from the egg. So they are very related with the age of the eggs, the quality of the eggs. So this being said, it's true that when we are using donor eggs, we are at the lowest possible probability of having a genetic abnormality, and in Portugal, the cutoff is at the age of 37. From 37 up, we can do PGTA. Obviously, egg donors have less than 35, so we cannot. In certain cases, we can ask for a permission to do PGTA on egg donation cases. For example, let's say we have 10 blastocysts, and we transfer one and have a negative result. We transfer two, we transfer three, and everything else is okay. We test the endometrium, we test the microbiota, we test for immune diseases, thrombophilia, wherever, malformations. We do an hysteroscopy, whatever. Obviously, this changes from a patient to the other, but if we don't see any other reason why for this embryo not to implant, we will not. It makes sense to test the other embryos, and so the IVF authorities, the IVF regulator in Portugal authorizes. We need to submit a request, and so most of the times they accept it, even though sometimes they reject it. Why? And it is also important and fair to tell that the ESHRE, the European Society on Human Reproduction and Embryologists, still considers that we shouldn't do PGTA to all cases. It comes down to personal beliefs and what we can expect. Like I said before, PGTA will not increase the chances of a pregnancy. Okay, it will tell us whether that embryo is viable or not, but the cumulative pregnancy rate, like Daniel was saying, will always be the same. So if for you it is okay to transfer 10 embryos to a patient in 10 embryo transfers, we know that at the end of it, that patient will, if only one embryo is viable, we know that after 10 embryo transfers, we will get one baby. Obviously, if we can know which embryo is viable and transfer just that one, we will be saving that patient to potentially 9 failed embryo transfers. Okay, so this is why I'm in favor of PGTA. If it saves just one failed attempt, then it pays off. Obviously, there's money involved. There are cases where PGTA is, even countries where PGTA is more expensive than others, where the costs are really impossible to bear, while there are other countries where it is state funded or insurances cover it. So the reality, the financial reality also plays a role. So my opinion on this is, if I was the regulator, yes, it would be something that I would advise. Since I'm not the regulator, it will depend on where you do your treatment. Obviously, when regulators and ESHRE, they set those guidelines, it's because when you do IVF with donor eggs, you get 65% of pregnancies. Okay, it's general results all over the world, and And if you do IVF with PGTA tested embryos, you also get 65% to 70% of pregnancies. So chances are more or less the same. So this is why they say, well, since PGTA doesn't improve the pregnancy rate, we don't recommend it. I don't think they are seeing the problem in the right angle. It's not about improving the pregnancy rates. We know they will not improve the pregnancy. It will not improve the pregnancy rates. It's about reducing the time to pregnancy, the number of attempts, the psychological, the emotional burden of the treatment, even the financial burden of repeated treatments, the stress in the couple. So then, obviously, it also depends on how much value do you put on that. Okay.
Amazing, thank you. I know we're kind of reached time. We've got just a quick question, if you don't mind, on so we've got quite a few questions about high DNA fragmentation, and some people have been asking if it's recommended to use ICSI or conventional IVF, and some have asked, is it normal to be experiencing lower embryo development with high DNA fragmentation? If we start with the first question, Dr. Daniel, what are your thoughts on conventional IVF or ICSI for high DNA fragmentation?
We do not perform conventional fertilization due to different reasons, mainly because of lack of fertilization even in normal spermic men, and we are protecting women from repeated stimulation. So it means we want to be on the safe side to have fertilization. I started IVF with conventional fertilization, and I saw a lot of failed cycles because of different reasons. Polyspermy, many times we had contamination due to contaminated specimen, and lack of fertilization even in normal spermic men. So now we perform just ICSI, definitely. Now let's go back to this DNA fragmentation, which is very frequently spoken problem in men. Everybody must understand that this DNA fragmentation can occur as a result of improper in vivo conditions and also in vitro conditions. So it means even in laboratories we can release of free oxygen radicals that can damage DNA. So it means, for example, in our laboratories we don't use any kind of centrifugation which can increase the DNA fragmentation. We use just simple separation methods based on the motility of spermatozoa. And let's go back to in vivo conditions, because frequently the DNA fragmentation is increased by prolonged state of ejaculate in epididymis. And you know very well that in many centers they will ask you to keep sexual abstinence for 3, 5, even 7 days before you provide specimen. We are doing opposite. We want to have a fresh sample. So it means we require our patients to have 6, 12, maximum 24 hours of sexual abstinence. And if we still have a high DNA fragmentation, we ask them to repeat to provide specimen after 2 hours. Or if even in such cases we still have a very high DNA fragmentation, we perform TESA. So it means we are going to surgical retrieval of spermatozoa. But of course, this is very rare case. Usually, this low sexual abstinence is enough to go under 10%. And if we combine it with very gentle semen manipulation in IVF, it's enough.
Thank you so much. And so I guess the second part of that question to you, Vladimiro, do you think that the higher DNA fragmentation can have an impact on the embryo development and potentially low blastulation rate?
I've never seen that shown, at least in a convincing way, in research papers. I think that's the short answer. We always kind of postulated that, but I don't think anyone has ever been able to demonstrate that. So I would say no, the problems probably arrive later with a higher miscarriage rate, lower implantation rates. Those are associations that are well documented. But also, just one note that is very important. Most of the DNA fragmentation studies are have technical problems. What does it mean? Because the way to assess whether there is really a DNA fragmentation issue in a sperm, there are different methods in the market. There is tunnel, there is comet, there is hollow sperm. And the problem with that is that not all methods are equally effective in identifying DNA fragmentation. And so, and DNA fragmentation is done with a sperm sample, and the treatment is done with another sperm sample. And they are subject to different types of lab manipulation, exposure, and so on. So this is extraordinarily difficult to assess. Okay, so I don't. I mean, I I really believe it has a role. Okay, I'm not saying it doesn't have an impact. What I'm saying is that when you look at the quality, the scientific quality of the studies that have been published, the lack of uniformity in the methods that were used, and so on, it's very difficult to reach conclusions. I was recently in an ESHRE Congress, the best of ESHRE and the SRM, and there were a lot of talks on these topics. People in favor, people kind of against. Some of the biggest specialists in the world, people looking at all the studies that were being published, right, saying, well, this one is good because of this and that and so on. And the reality is what Dr. Hlinka was saying is right. Okay, so but the reality of these studies is that we don't know. So the best solution is try to have more sperm collections, less time of abstinence, try to work in the best possible lab conditions. Apparently doing ICSI is more favorable, but I've also seen studies showing otherwise. But the reality is that using Zymot could be a solution. There are other things in the market, but the reality is that we don't know.
Yeah. And I think that came up here a few times as well in Zymot and the impact on actually the potential to reduce the DNA fragmentation. Dr. Daniel, go for it.
Just final sentence to this problem, because if we compare how the egg is influenced, the embryo of development, how the spermatozoa and this spoken DNA fragmentation, I consider DNA fragmentation to be so minimal effect on the embryo development. So we have to focus on oocyte quality, on stimulation, at egg of the patient, etc., etc. So it means that there is no need to overestimate DNA fragmentation, and this is why we don't mind it. We just shorten the sexual abstinence, and that's enough.
Excellent, thank you. And I think that was another question here. Somebody's asking, is poor embryo development more related to the sperm or egg quality? And I think that is also, that opens up an interesting conversation around the timing and the when we're looking at the embryo development, what it could be more related to. What are your thoughts on that, Vladimiro?
Well, it will you were saying half of the answer. So it's no, I would say it will depend. Obviously, in the first 3 days, I would say it's the egg. From day 3 to the blastocyst stage, I want to call it day 5. It's well, the sperm takes section. So I wouldn't say it depends more on the sperm than on the egg. It will probably, if there are problems with the sperm, they will be more visible after day 3. But the reality here is that, again, I also already mentioned one conference that I saw a few years ago at one of the ESHRE is the European Society meetings, where a genetic specialist was justifying everything with basic genetic science. Apparently 70% comes from the egg, 30% from the sperm. I don't know how did he got to this percentage, but intuitively it sounds plausible, I would say.
Excellent, thank you. Dr. Daniel, go for it.
Again, it is case to case, because this is a problem in particular cases. Because if we are speaking about sperm-related failures of, for example, fertilization, yes, because it is a very rare situation when sperm is not able to activate the oocytes, so it means that it lacks phospholipase, one enzyme which starts fertilization. But during my career, I've seen 5 such cases. So it means let's compare to fertilization failure due to atretic oocytes, and then we have to consider that there is one very important part of spermatozoa. This is centrosome. Centrosome is inherited because it contains centrioles. These are organelles which are lost during oocyte development. So it means oocytes brings mitochondria, and the spermatosome brings centrosome containing centrioles. And in this organelle is part of sperm tail. So we are facing some situation in a totally very severe OTA syndrome, oligoteratoastenospermic man, or in cryptospermic man, or of a very bad test situation, azoospermic man, having abnormal behavior of tail. And in such cases, even this centrosome is abnormal. And if such a spermatozoa are fertilized, we can face abnormal cleavages, because the centriole is responsible for polar pores of spindle formation. Spindle is responsible for embryo cleavages. So it means in such a very abnormal spermatozoa, we can face the situation when the spermatozoa cause abnormal cleavages of embryos. In such a situation, because in such situation you cannot preselect viable spermatozoa which are progressively motile. In such a case, it's better to choose donor spermatozoa. Otherwise, you the woman would suffer from repeated stimulations.
Okay. Thank you so much for that. I'm so sorry for those questions that we haven't managed to answer tonight. Tonight's topic was around embryo quality and are the best looking embryos the best choice for transfer. We will host other Ask Your Embryologist events. Look out for the next one next month. I do thank you very much, Dr. Daniel Hlinka and Vladimiro Silva, for your time this evening. It has been lovely chatting with you both. For everyone who've joined us as well, thank you for tuning in tonight. Keep your eye out on other events that are upcoming on My IVF Answers. And yeah, the recording will be made available tomorrow. And have a lovely rest of your evening, everyone. Thank you.
Thank you so much.
Good
Good luck
night.
for everyone. Bye-bye.
Thank you.
Bye-bye.
Take care. Bye.
Bye-bye.